What happens at the time of progressive disease for patients like this who are with the typical EGFR mutation who are treated with first-line regimen? Well, if the patient has a progressive disease that can be readily biopsied, I typically will try to get a tissue biopsy. If not, I'll order a liquid biopsy. Now, liquid biopsies have the benefit that, of course, it's less invasive to getting a blood test than a tissue biopsy. They have the drawback that they don't always detect the alterations. Typically for EGFR mutations, most studies show that they detect somewhere between 85 and 90% of the EGFR mutation. I think our experience is consistent with this. So they're very good, just not perfect at picking up alterations. I think it's reasonable to start with either option. I do think it's important to test at the time of progressive disease for patients with EGFR mutation because there are alterations that can occur that are targetable. And now, what are some of those alterations? Well, if somebody is getting a drug in the first-line setting, a first or second generation drug like erlotinib, then they have close to a 50% chance of developing a T790M secondary alteration. And in the Relay study, whether patients got erlotinib alone or erlotinib with ramucirumab didn't seem to really impact the resistance mechanism. In both cases, T790M was detected in roughly half the cases, and that was just by looking at liquid biopsy. And if they did have T790M, then osimertinib would be indicated. Now, what if you start with osimertinib? Well, if you start with osimertinib, we don't have any FDA-approved regimens, but we do have a number of good clinical studies for patients who have progressive disease. So, for example, if you develop a MET amplification, we have a number of studies now testing MET inhibitors combined with EGFR inhibitors that show really promising activity. So some of the MET inhibitors that are in clinical testing right now include savolitinib, capmatinib, and tepotinib, and they all show promising results in this setting. It's possible to get additional EGFR alterations, and some of those additional EGFR alterations may actually be responsive to other EGFR inhibitors. So I do think it's important to do testing. There have even been reports, there was one from Zofia Piotrowska and colleagues at MGH, where they showed RET fusions coming out in patients with EGFR inhibitor resistance. And in fact, there was a response subsequently to a RET inhibitor. And we've also seen RET fusions arising in the setting of EGFR inhibitor resistance as well. So I do think it's really important for patients to undergo molecular testing at the time of progressive disease. And I think the good news is that more treatment options are coming out for patients who do have progression after EGFR inhibitors. So right now, the most common one for somebody who starts with erlotinib will be osimertinib if you have T790M. But I expect in the near future, there'll be a lot more options emerging. Now, what other treatment options are there for patients who progress after an EGFR inhibitor? Well, if they don't have a targetable alteration, then chemotherapy certainly remains an option. Personally, I always try to incorporate a VEGF inhibitor with chemotherapy. So, for example, the ECOG 4599 regimen with carboplatin, paclitaxel, and bevacizumab, or the Empower 150 regimen, or find some way to use bevacizumab with platinum doublet chemotherapy, just because we know that EGFR patients do depend on the VEGF pathway so much. The Keynote 189 study, which had tested platinum doublet with pembrolizumab, did not include patients with EGFR mutations. So for patients with EGFR mutant non-small cell lung cancer, the Keynote 189 regimen is not currently FDA approved. So I typically would use platinum doublet regimen, try to include bevacizumab, wherever possible, as long as the patient didn't have a contraindication to bevacizumab. And I reserve immunotherapy for after platinum doublet chemotherapy, unless the patient really had very high PD-L1 levels. If the patient had a PD-L1 level of a greater than 50%, I might consider doing immunotherapy first, but it's very rare for patients with EGFR mutations to have a PD-L1 level that high. Typically, they have low PD-L1 levels. So platinum doublet would usually be the next regimen, and then considering immunotherapy or docetaxel or docetaxel ramucirumab after platinum doublet. So we really want to stretch out the period of time for which patients are on an EGFR inhibitor. And I think this is an important concept. I think patients being treated for EGFR mutant non-small cell lung cancer really think of their time on EGFR inhibitors where their quality of life really is usually very, very good, really dealing with some mild, manageable side effects from the EGFR inhibitor. And then when they stop on an EGFR inhibitor and move to chemotherapy, that's often where the quality of life can be compromised by the treatment to a significant extent. The treatment is still worth carrying out, but I think most oncologists really try to stretch out that period of time on EGFR inhibitors for as long as possible. Let me mention one other option. For people treated with the first-line EGFR inhibitor who only have progression at a couple of sites, we call that oligoprogression. I'll often recommend local therapy to those sites. So for example, let's say this patient subsequently had progression and there was only one bone metastasis or bone metastasis in one spot in the lung. I would commonly radiate those two spots. And then if the patient had a T790M, switch over to osimertinib. If they didn't have a T790M, I'd often continue the treatment that I was using. And in fact, we recently reported for patients on osimertinib that if you consolidated them at the time of progression with radiation, they could go on for another year on osimertinib. So this shows you that even after progression, with consolidative radiotherapy, you often can get durable benefit afterwards. So I think we want to be as creative as possible at figuring out how to keep using EGFR inhibitors for as long as it's clinically indicated, either by finding alterations that can be targeted in combination, like T790M, or consolidating the sites of progression if it's only a couple, and continuing the regimen.